Hello, my name is Becca Shelley, and I'm a senior in Brittany Allen Peterson's lab in the Department of Biological Sciences. Today I will present my work in the role of PP2AB56 alpha in KRAS driven transformation of pancreatic epithelial cells and the progression of pancreatic cancer. Despite being the 10th most diagnosed cancer in men and 9th in women, pancreatic cancer is the 4th leading cause of cancer-related deaths. The 5-year survival rate for all pancreatic ductal adenocarcinoma patients, or PDAC patients, is less than 10%. This poor prognosis can be attributed to both the aggressive nature and the late diagnosis of the disease due to the difficulty of detection of pancreatic tumors. At least 95% of pancreatic tumors occur in the exocrine pancreas, which contain ducts that carry digestive enzymes made by cells in the pancreas into the intestines. The most common of the exocrine tumors is PDAC, which develops from ductal cells in the pancreas. KRAS hyperactivating mutations like KRAS G12D are extremely common in PDAC and promote downstream KRAS kinase signaling cascades that further promote oncogenesis. Pancreatic tissue is made mostly of normal acinar cells with fewer ductal cells. KRAS is considered an initiation mutation in PDAC and causes uncontrolled cell proliferation and aberrant cell survival. As cells adapt a ductal phenotype and acquire additional mutations over time, they become increasingly dysplastic and have increased stroma. KRAS is a GTPase, which is inactive when bound to GDP and active when bound to GTP. GAP proteins assist in the removal of the activating phosphate group from KRAS, moving KRAS back into its inactive form. A KRAS G12D mutation prevents the GAP protein from binding, so the KRAS protein remains in this active conformation. The GTP-bound state of the oncogenic KRAS prevents the binding of inhibitors, and there are not many other binding pockets present on KRAS itself, so as a result, KRAS remains a difficult target for therapeutic intervention. Instead of targeting KRAS directly, a different angle to stopping the downstream signaling of KRAS is to suppress the downstream effectors themselves. This would also decrease the expression of oncogenic phenotypes while bypassing KRAS targeting. And this is where the protein PP2A comes into play. The protein phosphatase 2A, or PP2A, is a phosphatase that makes up approximately 50% of the cellular phosphatase activity, and it also functions as a suppressor of many of these downstream oncogenic kinases. The PP2A holoenzyme consists of 3 distinct subunits: the scaffolding subunit A, the catalytic subunit C, and the regulatory subunit B. While the A and C subunits only have 2 variants, the B subunits have 4 distinct families of subunits that consist of 3 to 5 isoforms. The abundance of B subunits allows a wide array of phosphatase substrates through the B subunit substrate recognition in the active holoenzyme. While PP2A has been characterized as an overall tumor suppressor, the activity of the PP2A holoenzyme can vary greatly based on the B subunit that is incorporated into the complex. A transformation assay in mouse embryonic fibroblasts showed that among a knockdown screen of PP2A B subunits, B56 alpha suppression had the greatest transformation and therefore is most likely to act as a tumor suppressor. In addition, a pan-cancer analysis found that B56 alpha is only mutated in 5% of the overall 8% patient samples with PP2A mutations, so B56 alpha has an approximate 0.4% mutation rate across all patient samples. This low mutation rate in PP2A B56 alpha allows the unique opportunity for therapeutically targeting a functional PP2A complex for reactivation in PDAC. Furthermore, in a panel of PDAC cell lines, the expression of cancerous inhibitor of PP2A, or CYP2A, is increased compared to the normal pancreatic epithelial cells, and the overall total PP2A phosphatase activity is lower in the screen of pancreatic cancer cell lines compared to normal pancreatic cells. This indicates that PP2A activity is likely suppressed by the expression of endogenous CYP inhibitors like CYP2A, which then further promotes the activation of downstream kinases by oncogenic KRAS. My central hypothesis is that PP2A B56 alpha loss cooperates with oncogenic KRAS to transform pancreatic epithelial cells, and that the downregulation of PP2AB56 alpha accelerates the progression of pancreatic cancer. I will be using both in vitro and in vivo studies to investigate this. To address my first aim, to determine if the loss of B56 alpha can transform epithelial cells when coupled with KRAS mutations, we generated stable cell lines from human pancreatic ductal epithelial cells, or HPDE cells, that have an inducible expression of either wild-type KRAS or KRAS G12D, and a stable knockdown of PP2A-B56 alpha. Soft agar, clonogenic, and proliferation assays will be used to assess if the cells have been transformed, and then protein and mRNA will be analyzed to determine signaling changes in the downstream effectors of KRAS. Soft agar assays test anchorage-independent growth in cells, which represents an oncogenic phenotype. Our preliminary data shows that while cells with B56 alpha and active KRAS have less growth in soft agar, a loss of B56 alpha along with KRAS activation results in more growth in soft agar, implicating that loss of B56 alpha with active KRAS promotes oncogenesis in these epithelial cells. And again, in another phenotypic assay called a clonogenic assay, loss of B56 along with active KRAS causes higher colony formation than in cells that have active B56 alpha. To address my second aim, which is to determine if B56 alpha loss with active KRAS enhances the progression of PDAC in vivo, we are comparing the tumor progression and characteristics of these tumors from KC mice that express mutant KRAS in the pancreas with KCB-KO mice that have this mutant KRAS in the pancreas but also have a full body loss of PP2A-B56 alpha. Listed here are some of the stains and markers that will be used to characterize the morphology and progression of the tumors, and to visualize localization of proteins and their expression within these tissues and within individual cells. I will be utilizing both immunofluorescence and immunohistochemistry. H&E staining identifies normal pancreatic acinar cell areas. At both 2 months and 5 months, KCB mice, or mice with active KRAS and a loss of B56 alpha, show further progression of tumor lesion formation and less overall healthy acinar area than the KC mice with only a KRAS activating mutation. These mice with a loss of B56 alpha also show a higher amount of collagen deposition at 5 months than the KC mice do. Alcine blue staining, used to mark pannon areas, indicates that KCB mice have a significantly lower healthy acinar area and have a higher number of pannon lesions per area. Together, all of these results indicate that a loss of B56 alpha can further accelerate early PDAC progression when coupled with KRAS G12D mutations in vivo. The future directions of this project include using the HPDEI wild-type and iKRAS cell lines with the loss of PP2A-B56 alpha to determine the signaling and phenotypic changes downstream of both the I wild-type and the iKRAS G12D protein with and without PP2A-B56 alpha loss. For aim 2, I will be continuing to characterize tissues from both KC and KCB-KO mice at 2 months and 5 months by the use of different tissue stains, along with both immunofluorescence and immunohistochemistry, to look at the expression of PP2A-B56 alpha inhibitors, downstream effectors of KRAS, and the immune populations and their localization within the cell and the overall tissue. Finally, we intend to further study if the suppression of PP2A-B56 alpha is critical in maintaining mature PDAC disease, and if therapeutic reactivation of PP2A-B56 alpha can be employed in mature PDAC disease as a way to counteract hyperactivating KRAS mutations. I want to thank every member of the BAP Lab for their assistance and support in this project, and I want to thank you all for listening to my talk.